Hello everyone. In this video, I bring to you some of the recall questions that the students have submitted after answering the INISS of November 2025, and I really thank them who have taken the effort actually to give us the questions, and I will be going over these questions for you all with explanations and the options as well. Now the first question is, which flap undergoes pre-ischemia conditioning before transfer to head and neck? When we talk about pre-ischemia conditioning, the simple word for this, when we consider surgical pre-ischemia conditioning, would be a delay procedure. So what this delay procedure does? What it does is that it will help a larger length of the flap to survive. Now, when I talk of larger length of the flap, what comes to your mind? You must remember in our angiosome chapter, we have seen what an angiosome means and what is the anatomical territory of that angiosome and how it can be expanded. How the angiosome anatomical territory can be expanded? We can expand it by the release of the choke vessels. Okay. So, one is the physiological territory and the anatomical territory. Anatomical territory is where the angiosome is supplying. But what is the expandable territory? The physiological territory is anything beyond the anatomical territory that we can include in the same flap. Then that becomes an extended flap. So, what we do days or weeks before the actual surgery, what we do is that we make a cut on the random part of that flap, which is not directly being supplied by that angiosome, so that there is a little more of the skin that we can include in the flap, so that the flap becomes longer for us to reach the place that it is intended to reach. Okay. So basically what it does is it improves the axiality of the flap. That means one flap is getting supplied by the artery. If we are including a wider part of it, then the axiality is improved. Maybe this was not the portion which was being supplied directly by this artery, but as we do the delay procedure, this axiality improves and the choke vessels will open. Okay. So, a random flap is being included in the original flap. Okay. Not supplied by that axial artery originally. So, it improves the axiality, number 1 point. It improves the distal flap survival. And why is that so? Because the choke vessels will be open. This ischemia that we are surgically inducing is making the choke vessels dilate and the connections between the two angiosome. So, this is the first angiosome and this is the second angiosome. This has its own supply, this has its own supply. There are choke vessels in between. This is a highly simplified diagram just for understanding. Now, this is the angiosome that was supplying here and this is the angiosome supplying here. What will happen is that if we are including this portion of the flap over here and we cut around like that. So, what is happening? This is stopped, the supply from this is stopped. So, this is not supplying here anyways. Now, the axiality of this will improve through the dilatation of the choke vessels. Okay. So, this is what is called pre-ischemia conditioning. There are other methods also with which we can do pre-ischemia conditioning, like when we partially block the pedicle, then also there is pre-ischemia conditioning. There are other chemical methods also through which we can do the pre-ischemia conditioning. So, what it does is it improves the distal flap survival. Okay. So, what we are doing is that we are subjecting the flap to an ischemic conditioning beforehand, before the flap is actually divided. So, we are reducing the blood supply from one side so that blood supply from the other side can be increased. Alright. So, pre-ischemia conditioning is that for you. So, let us see now the options: DP flap, ALT flap, pectoralis major flap and gracilis flap. So, when we talk about pre-ischemia conditioning, another thing that I would like to tell you is mostly it is done for the regional or the local flaps that we rotate. Okay, mostly. But in case if we want to do it for a free flap, why would we do it for a free flap? Because free flap anyways, it is being taken from one place and being transferred to the other place. There we are doing microvascular anastomosis. So immediately the perfusion is returning. So why would we do a pre-ischemia conditioning in a free flap? If we want to increase the area of harvest of the skin that we want to be included in the flap. So maybe that could be one reason. The other reason could be that if the ischemia time we feel will be prolonged when we can transfer the flap to the location of the area which we are wanting to put it in. So if that ischemia time is going to be prolonged, then we can do a pre-ischemic conditioning of the donor flap. Now in this, it is very easy for you to see that the answer would be deltopectoral flap. Because if we are saying the transfer to head and neck, obviously, and we are talking about a pedicled rotational flap, right? So mostly in pre-ischemia conditioning. So deltopectoral flap would be the answer. Now let us look at what the DP flap is. You know the DP flap, what is the supply? The axial supply of the DP flap is, mostly it is second intercostal perforator from the second intercostal. Okay, so second intercostal, it's the main one, and the third and the fourth are also supplying it. But the main is the second intercostal perforator, which is right here. Okay, this is the second intercostal space, and this is the perforator from the internal mammary system, the intercostal perforator. Now, this is the DP flap. Okay, this is the DP flap. This is the deltopectoral groove marked in red for you. This one. This is the deltopectoral groove. Pectoralis major muscle and deltoid. So this is the deltopectoral groove in between them, and that is your region of the DP flap angiosome. Means if we are wanting to harvest this much, no need of any pre-ischemia conditioning. This is the angiosome automatically being supplied by the second intercostal perforator. Okay. So for this we would not need any pre-ischemia conditioning because it is good survival on this. But if we want to include the area on the deltoid muscle within this flap, if we want to include this particular area which is on the DP flap, not originally being supplied by this axial artery of the second intercostal perforator, then what will we do? We will do a pre-ischemia conditioning by making a cut over here a couple of weeks before the surgery. And so what is the main supply of this? The main supply of this area originally would be the musculocutaneous perforators from the deltoid muscle and acromiothoracic or acromiothoracic artery, right? So this is the original supply, and these are the adjacent angiosomes. But what we are doing is we are making a cut and elevating the flap also, not just making a cut, because the musculocutaneous perforators are coming from inside the deltoid muscle. So it is going and entering. So if we just cut it, it is not enough. We have to cut and raise it and then place it back over there and stitch it. So what we've done, we've transected the original angiosome supply of this part of the skin. Okay. So what will it do? It will make the choke vessels between these two angiosome territories open up. And now what is happening? This particular skin has no choice but to be supplied by this axial artery which was originally supplying this part of the skin. So now the choke vessels are open. There will be blood flow through these choke vessels, and it will have some neoangiogenesis over here, and it will become it will come in the territory of this deltopectoral flap, and it will be easy for us to transfer the flap to the head and neck, because usually the deltopectoral flap, the reach of it, it's not great, okay? And most of the time, if we want to have success with the deltopectoral flap, then we will need to include this part of the next angiosome territory into this, and this is called pre-ischemia conditioning, okay? So, this is the whole concept of the pre-ischemia conditioning, all right? Now, the second question is, cloverleaf skull is seen in syndrome with craniosynostosis with hypoplastic mandible in all except Apert syndrome, Crouzon, Pfeiffer and Schedler-Shorten syndrome. So, the answer, of course, you will remember from the craniosynostosis lectures that we've done that the cloverleaf skull can be found in all of these, but not in Schedler-Shorten. If you are forgetting, let me just give you a little refresh of the memory from the explanation. So, what happens is that it results from premature intrauterine closure of the metopic, coronal and lambdoid sutures. So, what happens? That's your metopic suture, coronal suture and the lambdoid suture. So, what is happening? These are fused, okay? So, growth stops over here. The growing skull cannot expand these parts of the skull anymore. So, what is happening? There is the sagittal suture that is left, and the growing skull will try to widen this sagittal suture and try to grow upwards, and it cannot grow in these directions at all. So, what happens? That the cerebral bulging will occur through the sagittal suture. So, through the sagittal suture, the brain bulge will occur because it cannot move forward, it cannot move sideways, it cannot move backwards. So, the only place that the growing brain has is growing upwards through the sagittal suture. And then the sagittal and squamosal suture may then close, giving rise to the characteristic trilobe appearance of the skull. So, what is the trilobe appearance of the skull? It is the cloverleaf skull. So, through this, you see how it is growing. On top, this skull grows, and this is the cloverleaf skull. So, it has many associations, and what are the associations? The associations are, so almost in 80% of cases, these are the associations, and you have all the three options listed here: Pfeiffer syndrome, Crouzon syndrome, Apert syndrome. So, those were in the answer. So, those are not, those are associated with cloverleaf skull. So, the only other answer is the Schedler-Shorten syndrome. Now, it is also associated with thanatophoric dysplasia. What is thanatophoric dysplasia? Thanatophoric is a Greek term which means death bearing. Means if there is this dysplasia, the child will not survive, and usually these children, if born, they will die at birth. So, this is a lethal skeletal dysplasia which has severe micromelia, narrow thorax and respiratory failure at birth, and that is why it is termed thanatophoric dysplasia. So, this is a type 2 thanatophoric dysplasia. There are other types also. The type 2 thanatophoric dysplasia is associated with the cloverleaf skull, and it is the most common cause of the cloverleaf skull, but it is not there in our answers. So, the other syndromes you already know. There is also Carpenter syndrome and amniotic bands that are associated with the cloverleaf skull. So, all these, the associations of the cloverleaf skull, just by heart them, and these would be the thanatophoric dysplasia, Pfeiffer syndrome, Crouzon syndrome, Apert syndrome, Carpenter syndrome and the amniotic bands. Now, let us look at a little more detail. So, what is a cloverleaf skull? Cloverleaf, you know, this is how the cloverleaf looks. So, trilobate, okay. So, this is the cloverleaf, and this is 1, 2 and 3 lobes. That is how the skull looks. Now, our answer, Schedler-Shorten, Just remember 3 or 4 salient points about this syndrome, that is low frontal hairline, ptosis, mild syndactyly, and some amount of the face hypoplasia will be there. Okay. So, these are the 3 most defining features would be this: low frontal hairline, ptosis and mild syndactyly. What is the suture involved? So, we saw in the cloverleaf skull, the sutures involved were metopic suture, coronal suture, lambdoid sutures, right? In the Sridhar-Sjorgen syndrome, only the coronal suture is involved. If a unilateral involvement is there, it will lead to brachycephaly. You know from the lecture on the craniosynostosis syndromes. So, it will be brachycephaly. So, the skull will not grow in the anteroposterior direction, and it will go on sideways. So, that is the bilateral affected coronal suture in the Sridhar-Sjorgen syndrome. It can also be unilateral craniosynostosis, and that will lead to plagiocephaly, which is like this. So, this is an asymmetric skull where this side has fused, so the skull is not able to grow in the AP direction over here, and it continues to grow like that. But this is normal, the sutures have not fused. This is normal coronal suture, metopic, sagittal. So, this side is growing normally, this side has stopped growing. This is unilateral affection of the coronal suture. Okay, that can also happen in this syndrome. So, low frontal hairline, ptosis, mild syndactyly, coronal suture is affected. It is an autosomal dominant inheritance. Okay. The intelligence of these children is near normal. Okay. So, the intelligence is not affected because the brain grows almost normally, although in a different direction. Okay. The severity, so you can well imagine that the severity of this syndrome will be milder if we compare it to, let's say, a PERT syndrome. So, because a single suture is affected, whether bilaterally or unilaterally, if a single suture is affected, then when we compare it to other syndromes, obviously these children will have normal intelligence and they are less severely affected than the other syndromes. Okay. The face I already told you, they can be asymmetry and some hypoplasia. Mainly the mid-face hypoplasia is seen in these cases. And what is the gene involved? If you can think, I'll just give you 10 seconds to think what is the gene involved in this syndrome, the Sridhar-Sjorgen syndrome. So, it is the TWIST1 gene mutation that happens in this syndrome. Okay. These are all independent questions. So, that is why I am going through in all this detail. So, it is important for you to know all of this. Everything in this question that I discussed just now is absolutely important. Okay. Go back to that lecture and revise if you have to. Now, let's look at the third question. So, the third question is, a child born with mid-face retrusion, proptosis and papilledema, which skull finding will confirm the diagnosis? See, this is a trick question. Okay. As soon as you see these 3 features, mid-face retrusion, proptosis and papilledema. So, what comes to your mind? All these 3 typical features are associated with a craniofacial dysostosis condition, which is the Crouzon syndrome. Okay. Now, let us look at the options. So, what will confirm the diagnosis? Whether it is harlequin deformity, copper beaten appearance, craniolacunia or sunburst appearance. Now, individually we have to know each of these, or you have to know the Crouzon syndrome absolutely perfectly to answer this question. So, what happens? Let us look at each option. Harlequin deformity. What is a harlequin? Harlequin is actually an Italian comic character in the earlier eras, and it defines a quizzical appearance, like when you're surprised like that. So, a quizzical appearance. So, what happens that in these, this is a radiographic radiographic appearance. And what happens that in the radiograph, you will see the superior orbital fissures very like a raised eyebrow appearance. So the superior orbital fissure, if we look at the skull in these cases, would be something like that. The superior orbital rim. So normally if it is like this, the superior orbital rim is like that, the superior orbital rim would be raised in these radiographs. So this is the Harlequin deformity. Okay. The second option is a copper beaten appearance. So what is a copper beaten appearance? Copper beaten appearance is when you take a hammer and you beat a copper sheet. What will happen? You will see the impressions of the hammer on the copper sheet. So that is the copper beaten appearance. If we translate that appearance to the skull, what will happen? So this is the outer table, this is the inner table. So if we hammer the skull from inside, what will happen? It is going to create these indentations. And this happens when there is increase in the intracranial pressure. So when there is increase in the intracranial pressure, it leads to this. So this is only the inner table. The outer table is not affected at all. So this is the characteristic feature of the raised intracranial pressure. So this is the copper beaten appearance. So craniolacunia. What is craniolacunia? Craniolacunia is a lacunar skull, meaning that there is honeycombing of the skull. So honeycombing of the skull happens, and when you look at the cross section, what is happening? In the cross section, there will be punched out appearance of the inner and the outer table, and that is how craniolacunia differs from the copper beaten appearance. In the copper beaten appearance, only the inner table is affected. In craniolacunia, it is both the tables that is affected, and they are punched out lesions in the skull. What is the sunburst appearance? Sunburst appearance, we all know that there is the growth like the sun rays, and you will see bony depositions like this. Very characteristic feature of osteosarcoma, right? So so when we look at the answers, what would be the defining feature of this Crouzon syndrome? You know, it is raised ICP, which is the diagnostic criteria in Crouzon syndrome, and that is why our answer over here is copper beaten appearance. Yeah, so let us look at the explanation in detail. So radiological appearance of prominent convolutional markings on the inner table of the skull is the raised ICP. Common causes would be craniosynostosis. Long-standing hydrocephalus is also one of the most important causes of the copper beaten appearance, and any space occupying lesion which will eventually lead to a raise in the ICP. Okay. So there would be abnormal head shape depending on what sutures are involved, and increasing head circumference in hydrocephalus will be there. Of course, there will be restricted growth in the craniosynostosis. So what are the features of the raised ICP? There's headache, vomiting, irritability, and poor feeding in infants, and a tense fontanelle. If the fontanelle is still open, then you will find that the fontanelle is tense, and delayed developmental milestones. What would be the visual symptoms? There will be papilledema and visual impairment. So in the hydrocephalus, there will be widely separated sutures, or in craniosynostosis, there will be premature fusion. So that was the whole description about the Crouzon syndrome. So let us look at the features again. So mid-face protrusion, proptosis, papilledema with increase in ICP is diagnostic of the Crouzon syndrome. Okay. So just coming back to the options again. So Harlequin deformity, when we think of all these combinations, mid-face protrusion, proptosis, papilledema, Harlequin deformity will not be a defining feature because it is also present with other conditions like Apert syndrome or Pfeiffer syndrome or Schroeder-Shorten syndrome. So it is not the one that will confirm the diagnosis. So this part of the question is very important. Now, craniolacunia is associated with neural tube defects like meningomyelocele and also other neural tube defects, Arnold-Chiari malformations and all. And sunburst appearance is with the tumors like neuroblastoma or Ewing sarcoma or osteosarcoma. So all these would be the options. But the one option that will confirm the diagnosis is increase in intracranial pressure, and that would lead to the copper beaten appearance. Now coming to the next question, FGFR2 is not seen in. So we have the options of Pfeiffer, Moehnke, Appert and Cruzon. So this is a very straightforward answer, and the answer would be Moehnke syndrome. We all know that FGFR2 is the gene mutation is seen in Appert-Cruzon Pfeiffer and also Jackson-Weiss syndrome. So the Appert-Cruzon Pfeiffer also is involved the FGFR1 gene in Pfeiffer and the Jackson-Weiss. Okay. Now we just discussed about the Scheider-Schwartzen, and that is twist1 gene. Moehnke is FGFR3. Okay, so that is your answer in this question. Whittaker classification is used for craniosynostosis, breast augmentation, abdominoplasty and brachioplasty. This is also a very straightforward answer, which is craniosynostosis. What is it? Basically, it is an evaluation classification. What does it evaluate? It evaluates the aesthetic outcomes after the craniofacial surgery, and particularly this is used for craniosynostosis syndrome correction. And the divisions are class 1 to 4. Class 1 is excellent aesthetic result where no further surgery is needed. Class 2 would be minor irregularities requiring no or minimal intervention later on, and class 3 is a major revision that is required, and class 4 is a totally failed surgery. So this would need significant revision. Okay, so there's a modified version of this classification also, and which is used to distinguish between the soft tissue and the bony areas. So soft tissue defects, the distinguishing classification is class A, and bony defect is class B. So there is the classic description in the Whittaker classification, and there's a modified version where we have divided the soft tissue and the bone separately. Okay. Now, true about web space is are all except. So, non-hair bearing areas in web space make an angle of 45 degree with the palmar surface. Third web space is smallest in width. The second and fourth web space have more width compared to the third, and non-hair bearing areas make a diamond shape. So, if we look at the options closely, if you really go to the depths of it, nearly all of them are correct options. Okay. So, non-hair bearing areas will make, so this, the web space is making a 45 degree angle with the palmar surface. So, this is the web space which is sloping, and then it is making an angle. Okay. Now, third web space is smallest in width, that is also correct. Second and fourth are larger than the third, is also correct. So, the most incorrect options of all of these would be non-hair bearing areas make a diamond shape. So, otherwise, even in some text you will find that web space, they are described as a diamond shaped structure. But if we have to choose one of the answers, then in my opinion it should be D. So, web spaces are interdigital areas with adjacent fingers. They are non-hair bearing, that is correct, and make an angle of 45 degrees with the palmar surface. They allow independent finger abduction and adduction, and third web space is narrowest, and the both the second and the fourth will be wider than the third. The dorsal skin is thin and mobile, while the palmar skin is thicker. They are lined by loose areolar tissue, which allows the flexibility for the movement, and they are involved in post-burn contractures, and that leads to syndactyly. So, post-burn syndactyly, and reconstruction will require to restore what all features? The depth, the width, and the natural contour and pliability of the web spaces to function properly. Cross-facial nerve graft was first done by Scaramella, Avenici, Schobinger and Gillies. So, the answer here is Scaramella, and he has significant work in the facial nerve graft. So, it was first implemented in 1968 to treat a 42-year-old female with facial paralysis following an excision of an acoustic neuroma. And in the refinement, the early reports were published by Scaramella and Smith in 1970s, which helped establish its use in reanimating the face, and it led to further developments. And originally, they took the sural nerve and tunneled it across the face, which connected it with the branches of the healthy nerve, and then we waited for the cross face to be again neurotized, and recover from the facial palsy. It is still used, this technique. And subsequent modification, which is by Anderl, which introduced multiple nerve branches and staged the procedure to improve the success rate. So they used only one graft, and now multiple grafts are used, and cross facial nerve grafting is still a very successful procedure for treating facial palsy. Next question, above what level of electric shock is high voltage? So this is also a very direct question, and above 1000 volt is considered high voltage, and this is the transmission lines, the railway lines, all these are more than 1000 volt. So when we classify this according to voltage, so this would be less than 1000 and more than 1000. More than 1000 also known as high tension or high voltage. Now these are the transmission cables which are in the range of 4000 to 11000 volt. And the electric trains are about 25,000 voltage. The underground trains are 25,000 volt in India and 11,000 in UK and some European countries. And when we see the low tension ones, then they are also classified into the low and the high voltage category. The low ones would be under 330 volts, and then that is divided into three categories again. So below 110, which is the auto industry, the storage batteries and all, and mostly these are direct currents. The 110 to 120 would be some domestic electrical appliances, not in India though. Okay, these are mostly in the American subcontinent. And 210 to 240 would be the European and the Indian subcontinent, Australia, Asia, Africa. We have all the electrical appliances that we use at home within this range, and in the US they have it in this range. Okay, and above 440 volts, which would be the industrial electrical burns. Okay, but they are not classically classified as a high tension, high voltage. Okay, that would be the transmission cables that we are using in the transmitting of electricity and using in the railways. So those would be above 1000 volts. Okay. So which intra-op method is shown in, so there was a figure, and that of course we could not get. Which intra-op method shown in the figure to look for muscle perfusion? Now let us look at the options first. Okay. A, spectroscopy, B, thermography, C, tissue oxygen, and D, USG imaging. Now let us look at the options in detail. What is spectroscopy? So this is non-invasive spectroscopy basically, and what it does is the infrared spectroscopy. So the infrared spectroscopy will give heat in the range of, or light in the range of 700 to 1000 nanometer, that will be absorbed differentially by oxyhemoglobin and deoxyhemoglobin. And then whatever we see in the picture, that the reflected light will form images, and from that we deduce whether it is oxygenated or deoxygenated. So basically it is the measurement of oxygen saturation, and it gives us the oxygen status, but it is non-invasive and indirect measurement. It is not a direct measurement, although this is very widely used for seeing the muscle perfusion, evaluating the muscle perfusion. Thermography will depend on the temperature. So what kind of temperature is being absorbed, and then that is being evaluated to see the perfusion of the muscle flap. Now tissue oxygen measurement. If we have this option, the direct tissue oxygen measurements via implantable electrodes or direct electrodes, or even transcutaneous or percutaneous oximetry is the most direct way you can see the perfusion of the muscle. So if this is the option, according to the figure, if this is the option given, then this is the most correct answer, but maybe they have shown a spectroscopy figure. So just go and research on all these figures that you can see what each means, and so that you can identify correctly. So what does thermography look like? What does spectroscopy look like? And tissue oxygen measurement, if there is an option, let's say the question was that which intra-op method is the most accurate in measuring the muscle perfusion, and we have this option, the tissue oxygen measurement or Clark's electrode or implantable electrode or let's say transcutaneous oximetry, then this would be the most correct answer. But most commonly used is NIRS. Okay. But the disadvantage of tissue oxygen direct measurement is what? It is that it is an invasive method. So you have to insert a needle if you're doing transcutaneous, or you have to have an electrode implanted. But if you are doing intraop, then everything is anyways open. So it is easier. But this is an invasive method, okay? And how do we classify this? So the 30 to 50 mm of Hg is normal perfusion, less than 20 is slightly compromised, and less than 10 is non-viable, okay? So this is the millimeter of Hg of oxygen saturation that we see, the pressure that we see. So this is used to evaluate the free flap, the muscle viability. Even in wound healing, this is important. In peripheral vascular disease, it is used, but the disadvantage is that it is invasive. If we have the option of which is the best non-invasive option, so then your answer would be spectroscopy, okay? And the ultrasound imaging will just see the flow. So the inflow and the outflow can be seen by ultrasound imaging. All these are indirect measurements. The thermography is also indirect, ultrasound is also indirect for the saturation, and the spectroscopy is also. So in ultrasound imaging, what we will see mainly is the flow and the direction of flow, whether there is any stasis and all, okay? So these were the options. So in this, the question, I have just marked which is the best option. But if the figure would be spectroscopy, then you have to mark according to that. Next question is unilateral upper eyelid with epiphora, axilla, hand and neck burn contracture, which will be treated first? So for this, we all know that eyelid with epiphora means that there is some exposure happening, okay? So this is the most critical thing to correct first, and that is why our answer will be eyelid. In burn contraction management, priority is given to vision threatening and life threatening problems. So upper eyelid contracture with epiphora, which has the risk of exposure keratitis, corneal ulceration and permanent visual loss. So always this will be corrected first. Neck, again it is important for posture, important for airway, it would be next. Axilla would be then third. There is functional limitation and it can be staged. So first we do proximal release and then distal release, and hand is also important because it is functionally critical. But out of all these, the most critical would be the eyelid surgery. A 24-month-old child who presents from a hilly area, who presented with cleft lip and cleft palate both, which will be the order of repair? A, first cleft lip then cleft palate, B, first cleft palate then cleft lip, C, only cleft lip and not do anything to cleft palate, and D, only cleft lip because too much time has passed. So just remember this, any time that a patient presents with cleft lip and cleft palate, always the sequence undisputably will be first cleft lip then cleft palate. Even if this was a child presenting around 9 months to 12 months of age, it would be the cleft lip and then cleft palate. The duration can be a little less. We all know that the cleft palate repair ideally should be timed between 6 months to 12 months because it will affect the speech development. Now, this is a 2-year-old child. The speech has already developed. Even if we repair the cleft palate, there are speech therapies, speech therapy which will be required. The result will not be the same as we would have repaired in the first year, but still the cleft lip deformity is the first that we will correct over here. So let us just look at this chart. So birth to 4-week, what we do? We do parental adaptation. The feeding has to be taught to the parents and the ruling out of other congenital malformations. So we will do counseling and we will do feeding advice and complete medical examination, okay? So in 0 to 3 months. So this is the first one I told you was the first month. Now from the first to the third month, what we do? Again, feeding is still important. Growth and development have to be monitored. The alveolar gap has to be seen. The nasal deformity, primarily, if we want, we can correct. So what we have to do is nasoalveolar molding has a role, pre-surgical orthopedics and nutritional assessment. Third month is the time of the cleft lip repair, okay? And you know the criteria. There's a very detailed lecture on cleft lip and palate. You must go through that. And it is a very important topic in all the examinations, interviews, everything. So this is a topic that you cannot miss. Cleft lip repair and primary rhinoplasty can be done, should be done in the third month, and anterior palatal repair also with gingivo-periosteoplasty. So that is the alveolar gap that we are talking about, okay? So this is the first surgical intervention that we are doing. Now, in 6 to 12 months, the priority is the cleft palate, speech and language development, and the middle ear effusion can be a problem. So, we do the cleft palate repair with soft palate muscle repair and the evaluation of the speech after that. Hearing evaluation is also important. Between first to fifth year, what do we do? The speech, again, it has to be a continued evaluation and intervention if required. The palatal lengthening procedures, if required, they can be done in this. The dental evaluation has to continue and hearing evaluation has to continue. So, in the year 5th to 6th, columella shortening, nasal deformity. So, this is usually the school going age, and here we can do a preschool rhinoplasty if it is needed. That is also very important, and columnar lengthening. Between 7 to 11 years, what is the most important procedure? It is the alveolar bone grafting. The secondary revision of lip and nose, it can happen again because sometimes the repair, if the first repair is not good or it has not yielded good results, then we can take our attempt at revising, because these children may face bullying at school, and that is also important to be addressed. Okay, and initiation of the orthodontic management will occur in this period. Between 13 to 18 years, what is important is definitive rhinoplasty. It is important in this stage. Continued psychological assessment, the speech and language, if it needs attention, we need to do that. And dental abnormalities, maxillary hypoplasia, these are the more important abnormalities to be taken care of during this time. Okay, malocclusion also. And in 18 years or older, then we do a definitive surgery about the nasal deformities, the skeletal abnormalities, all can be addressed after that. So, the definitive open rhinoplasty, it has a range. So, from the late teens to adulthood, we can do this, and we address the unresolved issues also. So, 70 kg male with 50% burns over the body, and he presented after 4 hours. Okay, what fluid management will you do for that patient? So, there's a very clear-cut option given: 7,000 in next 4 hours, 7,000 in next 8 hours, 14,000 in next 4 hours, and 14,000 ml in the next 8 hours. So, you know the easiest formula. Usually, these questions are asking for the Parkland formula: 70 kg male, 50% burn, 4 ml per kg per percent burn, right? So, it gives you 14,000 ml, right? So, this is the total in 24 hours. And what do we do? Half and half. So, in the first 8 hours and then half in the next 16 hours. 4 hours have elapsed, doesn't matter. 4 hours of the first 8 hours are left. So, we give entire half in the first 4 hours. Okay, so that is your answer. 7,000 ml in the next 4 hours. So, this is just a tabulation of all the formula that you should know, and this is your Parkland formula. It has no colloids, and again ringer lactate in the next 24 hours post burn. Here we don't give, and colloid is given in like 5% albumin and given at 0.3 to 1 ml per kg per percent burn, and 16. So, for 16 hours it is given. Okay. So, this is important, and of course, there are other formulas also: the Evans formula, Brook formula, modified Brook formula, and the Cincinnati formula, Galveston formula. Just go through all of these. These have already been dealt with, but yeah, this is important because it will be asked repeatedly. Okay, and these are very direct questions. You should not do any mistake in these questions. So, these are very direct. If you are making a mistake in these, then as I told you in other lectures also, I have told you that it is very important to do the common questions correctly, and then you come to the difficult questions. So, if you answer the common questions correctly, half the job is already done. Okay. So, this we already saw. Next question is, which of the following is not used as a method of facial reanimation after acoustic neuroma excision? So, conservative management, cross-facial nerve grafting, free functional muscle transfer, and sural nerve. So, not used as a method of facial reanimation. So, obviously, all these are legit methods of facial reanimation. The answer would be conservative management. We don't wait for the conservative management. So, cross-facial nerve graft, it leads to a dynamic facial reanimation. Free functional muscle transfer, which is most commonly what is used, gracilis muscle is used. So this is dynamic facial reanimation. So you can also get questions like, indirect questions like facial palsy case is there, and we are planning a free functioning muscle transfer. What is the Matthies-Nagai type of the muscle that you will use? So you should know first what muscle we are using, and then you should know what is the classification of that muscle. So it is an indirect question. So you should know both what muscle is being used and Matthies-Nagai classification. So this is gracilis, and you should know the MN classification of this also. Sural nerve used as a nerve graft in facial reanimation procedures. This is very common, and conservative management is observation of physiotherapy, which is not in the reanimation. Okay, so coming to the next question. Fibula with skin is which type of flap? Cormack A, B, C, D. So this is also a very direct question, and you all know that when bone is included in the flap, then it is Cormack-Lamberti type D classification, and this is the classification of the faciocutaneous flap, where the type A is multiple large supply at one end, then type B is single large, then there is multiple small segmental supply, and one with the bone, which is type D. Okay. Trapezius is which type of muscle in Matthies-Nagai classification? And again, this is a direct question, and the answer would be type 2 Matthies-Nagai. So a type 2 pattern is what? Type 2 pattern has one dominant and multiple minor pedicles. So this is the trapezius flap, which has a dominant pedicle and multiple minor pedicle. The lower part of it sometimes is classified as a type 5, which has one dominant and secondary segmental pedicles. Okay. Now the trapezius muscle is divided into three parts: the upper, middle, and lower part. The upper, which are the descending fibers, they are mainly supplied by the occipital artery, which is from the external carotid system. The middle part, which is the transverse fibers, the main supply would be the transverse cervical artery via its superficial cervical branches. The lower part, which is the ascending part, is supplied directly by the dorsal scapular artery, which is again a branch of the subclavian artery. So what are the systems involved? The subclavian and the external carotid systems are involved. The upper part is through the external carotid system directly through the occipital, and in the lower two there are the subclavian, it's the subclavian artery that is involved. The main supply is the transverse cervical artery, okay, and that is the dominant supply of the trapezius muscle. So the transverse cervical artery is the dominant supply, and the others are secondary pedicles, which is the dorsal scapular and the occipital. Occipital is from the external carotid artery, dorsal scapular is from the subclavian, and transverse cervical is also from the subclavian artery. Okay, this is a type 2 flap. Pec major belongs to which type of flap? Again, 5. I think if I have to tell you, perhaps this is the most common MCQ. Every time they ask it, every time. So one question for you is already given. Pec major has to be there in any exam that you answer. So it is a type 5 flap. We all know that in this also we will have to have a dominant pedicle, and here the dominant would be the thoracoacromial artery. Okay. And what are the other supplies? It would be the lateral thoracic artery and perforators from the internal mammary system. Okay. So this is the lateral thoracic over here, and these are the perforators from the internal mammary system, but the main supply is the acromiothoracic artery. Okay. Compartment syndrome, first clinical finding would be numbness and paralysis, pain on passive movement, pulselessness or swelling. So here also we should remember the 5 P's, and according to that, if you critically assess, all of the other answers would be slightly delayed in the presentation. Pain on passive movement would be the early onset clinical finding. So pain on passive movement is your answer. What are the 5 P's? Pain, pallor, paresthesia, paralysis and pulselessness. Usually paralysis and pulselessness, these are later signs, right? And the paresthesia also somewhere in the middle it will occur, but pain on passive movement, it will be initial. which wetting solution has less than 1% bleeding risk? Tumescent, dry and wet, super wet, and non-tumescent. So if we have to quantify now whether it was less than 1% or 1%, you have to see. So if it is, I think it is less than 1% that they would have asked. But if it is 1%, then the answer would be different. If it is less than 1%, answer would be slightly different. But when we talk about tumescent, the bleeding rates are really, really low. So in some texts, you would also see that they have been, they have said it is 0.3%, 0.1%. Okay. So this, I don't know whether the recall question is absolutely correct or not, but tumescent would be really, really low risk. Okay. So here I have marked it as super wet. So around 1% if it is there, then you have to mark super wet. Okay. But if it is saying that minimal, very less, much lower than 1%, so you can mark the tumescent method also. But we just look at the details. So basically, dry technique is no infiltration. So there is 25 to 40% blood loss, which is no longer used, of course. Wet technique is 200 to 300 ml infiltrate per area, which is 4 to 30% of blood loss. Super wet is 1:1 and it has 1% or just about like less than 1%. But tumescent would be much less. In text, if we look at the articles, it is also written 0.2, 0.3. So again, depending on what the question is really, I really wanted to write the answer as super wet, because if I would just write tumescent, then you would miss the details altogether. So just look at the question carefully. And in the super wet, 1:1 infiltrate to aspirate ratio. So in this, it would be approximately 1%. Okay. What is the Wallent technique? Local anesthesia with tourniquet, local anesthesia without tumescent, wide local anesthesia, no tourniquet, wide local anesthesia, no tumescent. So this is confusing, but the answer would be wide awake local anesthesia, no tourniquet. Okay. So this is your Wallent. So WALANT. So that's your method. This is also a very direct question. It typically utilizes the amides, the lidocaine and bupivacaine, and they block the sodium gated, voltage gated sodium channels, and they decrease the pain sensation, and they are metabolized through the liver. In local anesthesia chapter, these details have been discussed, and epinephrine is used in combination, and what it accomplishes is that they activate the alpha adrenergic receptors, causing vasoconstriction of blood vessels, and it also delays the systemic absorption. Okay. Zone of adherence in liposuction is all except. Now, middle medial thigh, lateral gluteal depression, gluteal crease, and proximal iliotibial tract. Now, this is also, so zones of adhesion in liposuction is very important to understand to give safe and a better result to the patient. These are the areas where there will be contour abnormalities which are most common in the zone of adhesion. Okay, so contour abnormalities which will be common, and vascular compromise of the tissues over it. Okay, so vascular compromise of tissues over it, if we see, then if we see the details, we all know that in the thigh, the medial thigh, when we look at it over here, is the adhesion zone. The lateral gluteal depression also, which is just above here over here. So the lateral gluteal depression in this area, in the lower area. So these are also zones of adhesion. The proximal iliotibial tract is not an area where there is zone of adhesion. It is the distal iliotibial area which is there in the zone of adhesion. So the answer would be proximal iliotibial tract. So this is the lateral gluteal depression over here. The gluteal crease is another area. The mid-medial thigh would be here, the iliotibial tract, obviously this one, all these are areas of zones of adhesion. Radius with radial forearm flap is which type of classification? Same question repeated, and you should know that it is the bone that is included and it is Cormack-Lamberti type D. Okay. Whole thumb amputation from the MCP joint, most common flap taken for reconstruction would be abdomen, pectoral, thigh and supraclavicular region. So, the most common flap we all know is the abdomen. Furlow's technique for cleft palate repair, it is a double opposing Z-plasty or a multiple Z-plasty or von Langenbach palatoplasty or intraviral veloplasty. Now, in some of the questions like I discussed the tumescent, the bleeding risk also, very few options were given. So, the option of tumescent liposuction was not given in that by the candidate who submitted it. So, just telling you, those have been put by me. So, just to complete the question, maybe all these options, all of them were not there. So, just to complete the question, I have put in the options, and in that only super wet technique and dry technique was given. So, that is why the answer I have put as super wet, but just to tell you the distinction that if it is saying less than 1% or very less than 1%, negligible, minimal, then your answer has to be different. Similarly, in this also, the options were only the correct option was sent by the candidate and other options were not there. So, I have just made the other options. So, double opposing Z-plasty would be your answer. Now, let us look at the Furlow's double opposing Z-plasty. So, why is it called double opposing Z-plasty? So, there are two Zs, okay, one on the oral side and one on the nasal mucosa. So, oral mucosa and nasal mucosa, they have two Zs. So, this is the Z of the oral mucosa and this one is the Z of the nasal mucosa, right. So, they are opposing Zs, right. So, one Z is like this and the other Z is like this. So, they are opposing Zs. And what is also most important is, what is the muscle it is repairing? It is repairing the levator velli palatini. It lengthens the palate and helps with the oral nasopharyngeal competence also. So, what do we see? We also see that the flap is posteriorly based. Posteriorly based flaps, you see. So, in this is the muscle. So, this is raised like that. So, this is a posteriorly based flap, and in this is the muscle. This is also posteriorly based. So, this one goes over here and this goes here. So, obviously, this muscle sling is getting created on the posterior part of the soft palate. Okay. So, this is your Furlow's double opposing Z-plasty. Going to the next question. Large wound area in forearm with tissue expansion for primary closure. Principle used is. So, tissue expansion, we know all the details from the lecture. Let's look at the options. Creep, Gillies, Crane and ischemic preconditioning. So, obviously, the answer would be creep. Now, creep is two kinds, mechanical creep and biological creep. You know that it is a gradual time dependent elongation of the skin under constant tension. And in the mechanical creep, what will happen? The reorientation and straightening of collagen and elastin fibers will happen, and there is no tissue increase in the real sense. In the biological creep, it is the real cell proliferation that occurs, neocollagenesis and angiogenesis, and then this results in the true increase in the surface area, which is the actual target of the tissue expansion. Median nerve repair is done by with suture, monocryl, nylon, polyglyperone and polydioxanone. It has to be nylon. This is also common. Laser for capillary hemangioma patch. We know that for laser, the answer would be PDL because it is a vascular malformation. So, PDL 585 nanometer is the answer, pulse dye laser. 585 to 595, and it targets the oxyhemoglobin. Which collagen is converted from type 3 to type 1? Granulation tissue collagen, basement membrane collagen, reticular fiber collagen or cartilage collagen. So, the immature collagen is present in granulation tissue and that is type 3 collagen. It changes to the mature collagen, which is type 1 collagen. So, the answer would be granulation tissue collagen. So early wound healing, it has type 3 collagen, which is thin also and immature. Late remodeling phase, which is thick collagen and strong, which is type 1 collagen. Okay. Now, what percentage of hypoglossal nerve is used for babysitter procedure? See, babysitter procedure, this might be a new term for you. Babysitter procedure is in facial palsy. What happens is that when we are doing reanimation procedures, so in reanimation, what are we doing? We are basically trying to revascularize the injured side, right? Re-neurotize the injured side. Okay. So, whether by cross-facial nerve grafting or free functioning transfer, whatever we are doing. So, but when the muscles are not receiving any input from the neurons, then what will happen? They will go subsequent atrophy, and even if re-neurotization has been occurring, it takes time. So during that time, what we do is that we take some assistance from another nerve to give some kind of motor signal to the muscle so that they don't atrophy, and that is the babysitter procedure. And most commonly, the nerve that is used is hypoglossal nerve. What percentage of the nerve? Because we cannot take the entire hypoglossal nerve. Obviously, it has to do its own function. So in that, we take a part of the hypoglossal nerve, which is 40% of the hypoglossal nerve is taken. And it is a two-stage surgical technique used in facial reanimation to treat facial palsy by preventing the muscle atrophy while waiting for the nerve regeneration. And it involves the connection of the 12th nerve to the 7th nerve for immediate babysitting, so that constant muscle stimulation is there. Okay. So, post-thyroidectomy patient has refractory hypocalcemia. Other than calcium, what other electrolyte parameters do we check in this case? This is mostly a general surgery question, but yeah, the answer would be magnesium. In a post-thyroidectomy patient with refractory hypocalcemia, the common overlooked cause is low magnesium, and this leads to the decrease in parathormone secretion, PTH resistance at target organs. So, calcium levels will not correct until the magnesium level is corrected. What is benediction hand nerve palsy? You know what is benediction hand? Benediction hand is the first two fingers are extended and the medial two are flexed. So this is a common thing that will occur in median nerve palsy, right? So your answer would be median nerve. So what happens is that when the patient is asked to make a fist, then index and middle finger they fail to flex. So something like that. So it's not flexing, and the ulnar digits are flexing, and the median nerve, we know it supplies the lateral FDP. So that means the index and the middle finger, the FDP supplies through median nerve, the other two ring and little finger, it is by ulnar nerve, and obviously all the FDS is supplied by the median nerve. So that leads to the benediction hand. Prefabrication is required in which flap for head and neck cancer surgery? Now this question can be a little confusing to you, but just remember that prefabrication is basically a blood supply, an area of blood supply that we are fabricating, which was initially not present. That means if we are prefabricating some place, some flap, then what it means that this area did not have that blood supply, and we are making that blood supply in the prefabrication procedure. Okay. So something like catching hold of the next angiosome territory. Okay. It's just the simple terminology like we are doing in the DP flap that we discussed earlier. So here also, when we look at the options, most of them are muscle flaps, and the answer would be DP flap. So prefabrication is an extra area of blood supply that we are including in the original design. In many cases, what we also do is in the reconstructive surgeries, that suppose an area we are wanting to harvest, but it does not have any axial blood supply. So what we will do, we will take a blood vessel and we will implant that blood vessel into that area, so that that becomes the blood supply of that area eventually, and then we harvest that area with the vascular pedicle, something like this. So you see this area, so this is the area in question that we are wanting to make the flap with, but it has multiple supplies. So what are we doing? What we are doing is that we are transecting this, and we are placing a tissue expander over here, and it is expanding this. So this expansion, what is happening? That this vessel is becoming the blood supply of this part, which originally it was not, right? Now you see, once the tissue expander is deflated, then this entire area can be harvested as one single flap. Okay. So this is the change of axiality of that of the blood supply of the area in question. That is what is prefabrication. Pre-lamination is when we include extra material, for example, cartilage we are doing or bone we are doing to pre-laminate and make a certain structure. For example, we can pre-laminate a nose on the forearm and then transfer that whole thing to the face. So that is pre-lamination. So this is prefabrication and the answer would be DP flap. Median ulnar nerve injury location based on deficit, deep laceration with lateral 3.5 deficit and loss of pronation. So the options are median nerve injury at the wrist, median nerve injury at the elbow, ulnar nerve injury at the wrist and ulnar nerve injury at the elbow. I have recorded very detailed lectures on the median and ulnar nerve palsy, and according to the question, the answer would be median nerve injury at the elbow because there is pronation also involved in this, right? So loss of pronation means involvement of pronator teres and pronator quadratus, which are supplied by the median nerve, which is proximal to the wrist, right? And sensory loss over the 3.5 digits, that is also classical median nerve territory. And at the wrist, pronation is preserved. Pronator is already supplied. So loss of pronation will be localizing the injury to above the wrist, which is the elbow. Pressure injury with tingling and numbness in both hands. Median nerve, ulnar nerve, anterior introitious nerve and posterior introitious nerve. Now, AIN, PIN, pure motor nerve. So, no question of any sensory deficit. Okay. So, the option remains as median and ulnar nerve. Median nerve, again, when we are talking about pressure injuries, ulnar nerve is more superficially located, especially at the area around the medial epicondyle node. So, and it is bilateral in both hands. So, the obvious answer here would not be this, but the ulnar nerve. Extracranial facial nerve blood supply, there were no options, so I have just written a little detail about it. So, the extracranial segment of the facial nerve is supplied by the stylomastoid artery and it exits the stylomastoid foramen through the parotid gland. It is supplied by the artery, which is a branch of the posterior auricular artery. Okay, but there are contributions from the superficial, temporal, transverse facial and occipital arteries as well. Now, this is the picture of a scar and the options are written. So, obviously, this is a keloid. And you know the difference between keloid and hypertrophic scar. The extent of keloid is beyond the confines of the original wound and it can develop even 1 year after injury. It rarely regresses and it grows often and it recurs often. The thickness is very high. The ground substance is large mucinous ground substance and in the hypertrophic it is scanty mucinous ground substance. This is also a question and the hypertrophic scar will regress spontaneously over 2 to 3 years. Now fibroblasts are sparse and scattered and here this is moderate to high density of fibroblasts. The collagen over here in the keloid would be densely packed and disorganized and in the hypertrophic scar it is shorter, flatter and loosely arranged. And the LDH, lactate and histamine would be increased in the keloid. The water content and soluble collagen is also increased. The immunoproteins are also present, which is not there in hypertrophic scarring, and pH is decreased. In hypertrophic scar, it is nearly normal, and collagen synthesis is very, very high in the keloid. And collagenase activity is almost 14 times higher than the normal scar, and in the hypertrophic scar, it is about 4 times higher. So, these are the different scars. This is a normal scar. And here what you see is a hypertrophic scar, and this is a keloid, and this is the atrophic scar. Already I have described all this in the keloid chapter. Burn surface calculation of both lower limbs, one upper arm and perineum. Now this was the question that was submitted. So if we calculate, so both lower limbs would be 18 and 18. So that brings it to 36. Now one upper arm, what I am thinking is that even if we are taking the whole arm, then if it is the upper limb, then it is 9%. And even if we are considering only the upper arm, then it has to be a different answer. But if we are considering upper limb, then that would be 9 and 1 for the perineum. So the answer would come to 46. So this is the chart, you all know about it. And again, I am reiterating, burn is very important. You cannot do any mistakes in this. So this was an image-based question of NPWT. Not true for its uses: non-debrided wound, large degloving injury, diabetic foot, and granulated wound. So we will not use it in non-debrided wound. So we will use it only after debridement. Okay. So it enhances the capillary flow, we all know that, and it is used in preparation of the wound for skin graft or flap. And surgical wounds are not amenable to primary closure, which are not amenable to primary closure, we can use in that also. For example, fasciotomy wound and abdominal compartment syndrome wounds. So subacute wounds and dehisced incisions, we can use it. And in chronic wounds, pressure ulcer, diabetic foot, venous ulcers, all this has the usage of NPWT. And it has been used in SSG dressing also for difficult areas where SSG take is doubtful. Then we use the split skin thickness grafting, and on top of that we use the NPWT. Okay. So Sudeck's dystrophy includes patchy osteoporosis, pseudomotor changes, trophic changes, and all of the above. The answer would be all of the above. Now, so this is a chart which has the symptom and the sign of Sudeck's dystrophy, and there would be sensory, vasomotor, pseudomotor, and motor signs and symptoms. And in the sensory, there would be constant burning pain, and pain is disproportionate in intensity to the inciting event. Okay. Also, there would be sensory abnormalities, which is pronounced more distally, and they have no consistent spatial relationship to the individual nerve which is affected. So, we can actually evoke the pain by stimulus, by mechanical and thermal stimulus, and it leads to hyperalgesia. Vasomotor, there would be temperature asymmetry, reports of skin color changes also. So, these would also be evident in the signs. In the pseudomotor, there would be reports of edema and reports of sweating changes. In the motor, there would be decreased range of motion, and it can lead to weakness, tremor, dystonia, or even coordination deficits. There would be the affected areas also include the hair, nail, and skin of that area. So, these can also be affected, and we can see the trophic changes in these structures. Closed clavicle middle third fracture with loss of abduction on ipsilateral hand. What is the management? So, what this points to? It points to the brachial plexus injury, because that is the place where the brachial plexus is traversing. So, this is loss of abduction of hand. It means the ulnar nerve is affected. So, that means we can think that C8T1 might be affected, and obviously the conservative management is not done in these cases because there is direct evidence of a deficit, a neurological deficit is there. So, we would do surgery. And reduction of clavicle, anyways it is not done, it is done with plating. So, reduction of clavicle would not be the answer. We have to mark the more general option, which is surgery, and we have to repair the nerve. Inhalational burns, there might have been some statements which was not submitted to us. So, I've just written that in inhalational burns, as I said, that all the burn topics are important and inhalational burns are more so. So, injury to the respiratory tract due to inhalation of hot gases, and it is very common in closed space, right. So, a major contributor to mortality in burn patients. And it can be an upper airway, lower airway, or systemic toxicity, which can be due to the carbon monoxide poisoning. And the clinical features would be singed hairs, facial burns, and burnt eyebrows. We can see the evidence of soot in the mouth or the nose or the respiratory tract. Then in the sputum, we can see carbon particles. There's hoarseness and stridor in the voice and respiration. There can be cough, wheeze, or dyspnea, and altered sensorium when there is carbon monoxide poisoning or cyanide poisoning, right? So, obviously the management you all know from the lecture on burns, but this leads to thermal injury, leads to airway edema and obstruction, and bronchospasm is there, mucosal sloughing would be there, there's carboxyhemoglobin formation, and the suspicion has to be very high for inhalational burns, otherwise we will miss it. So, bronchoscopy is the gold standard diagnostic method, and arterial blood gases will show the carboxyhemoglobin to be increased, and the chest X-ray may be paradoxically normal in the early cases. So, we have to give 100% oxygen, early intubation has to be done, otherwise there will be edema and we cannot intubate, then we have to do a tracheostomy in those patients. And bronchodilators, chest physiotherapy, treatment of carbon monoxide poisoning by 100% oxygen and hyperbaric oxygen also if indicated. It has to be done, and we have to avoid over-resuscitation in these patients. So, now there was a question perhaps on the profunda artery perforator flap versus the tug flap, and I have just made a chart for you to compare because the options were not given. So, the full form would be the PAP flap and the tug flap. The full form is profunda artery perforator flap, and this is the transverse upper gracilis flap. Now, this is a perforator flap and this one is a musculocutaneous flap, okay. The vascular supply would be the perforators from the profunda artery, and here this is the medial circumflex femoral artery, the ascending branch. There is no muscle in this flap, and this is gracilis muscle. The donor site is posteromedial thigh, and this is the upper medial thigh. Okay. Now, the skin petal here would be oblique and transverse. Here it is mostly transverse. The flap volume is moderate to good, and this one is moderate. The pedicle length here is typically longer, and this one is a shorter pedicle length. The pedicle diameter here is smaller, and this is larger. So, this is short and large, this is long and small. The donor side morbidity in this is very less, and here this is because this is a muscle involved, so obviously the donor site morbidity will be more. The scar visibility, this is hidden in the posterior thigh, and this is hidden in the groin crease. So, this is near the groin, this is near the posterior thigh. The position during harvest would be prone or frog leg position, and this would be supine. Now, the ideal patient would be thin patient, and for the tuck flap in a patient with small breast, we use it for breast reconstruction, which needs the muscle bulk. And in this one, the optional sensory supply can come from the posterior femoral cutaneous nerve, and in this one, it can be the obturator nerve, which can be coapted. So, that is the pap flap versus the tuck flap. Now, there was a question on lower lip, oblique, mandible, 2 centimeter lesion. So, the flap choice. So, I have just made a chart for you for the lower lip reconstruction. Now, the defect size, we know that less than 30%, and in children less than 20%, we can do primary closure. 20 to 80%, whether it is central or lateral, the management would depend on that. The central can be a VW excision and plus minus the vermilectomy if needed. And in the lateral, it would be a slander flap. If it is more than 80%, bilateral carapanzic, nasolabial, submental, or a free tissue transfer can be done. Okay, so and pre-lamination, prefabrication, we just talked about it, that can be incorporated. And in the nasolabial, if needed, we can also do the FAM flap, and in the free tissue transfer also the facial sling for the action if the nerve is injured can be done. So, this is just a refresher kind of a slide, but you can go back to the lip reconstruction chapter and read that in detail. Now, there was a question on ALT flap monitoring picture. We've already discussed this in detail in a previous slide, but I'll just tell you a few points about the flap monitoring. So, most important is the clinical monitoring. If there's a question regarding this, then clinical monitoring takes precedence over the other methods. So, color should be pink, which is normal. If it is pale, then we have arterial insufficiency. If it is blue, it is venous congestion. Temperature should be warm, and if it is cold, it is arterial compromise. Capillary refill, which is normal, is less than 2 seconds, so 1 to 2 seconds. If it is delayed, it is arterial problem. If it is a rapid refill, then venous congestion. Turgor, if it is soft, it is normal. If it is tense, then it means venous congestion. If there is bleeding on pinprick, bright red, then it's normal. If it is absent, arterial compromise. If it is dark and slow ooze, then we know that it is venous congestion. There can be Doppler-based monitoring also. A handheld Doppler confirms the arterial signals. An implantable Doppler, like we saw in the earlier slide, continuous monitoring of anastomosis, especially in the free flaps, we can do. So, what are the advanced monitoring methods? NIRS, we talked about it. The infrared spectroscopy, which indirectly measures the tissue oxygen saturation. There are surface temperature probes. Then there's thermography also. So, photoplethysmography, laser Dopplerflowmetry, microdialysis, which detects the metabolic changes of lactate, glucose, and everything. So, all this is indirect method. And the tissue oxygen, as I told you earlier also, that it is a direct measurement. So, there was a question on cubital injury. Now, I don't know what the question was, but we can just discuss what is the cubital fossa, a triangular depression on the anterior aspect of the elbow. The boundaries, you know, there's a superior boundary, which is the line joining the medial and lateral epicondyles. Medial is pronator teres, lateral is brachioradialis, and the apex is where the two muscles will meet. And there's the floor. So, floor has brachialis and supinator. Now, roof is skin and superficial fascia, which contains the medial cubital vein and medial and lateral cutaneous nerves of the forearm, and deep fascia, which is reinforced by the bicipital aponeurosis. So, all these structures are there. Now, perhaps the question would have involved the median nerve injury, or which nerve is likely to get injured, or what are the signs and symptoms that a cubital fossa injury will have. So, probably something around the functioning of the hand or the functioning of the upper limb after the cubital fossa injury. So, you have to know that these are the important structures that are there and they can be injured. So, lateral to medial, maybe this could have been the question, lateral to medial. So, there is the tendon of biceps brachii, the artery is brachial artery, and the nerve is median nerve. Okay. So, any of these could be your questions. So, neurovascularization timing in the skin graft, and again it brings us back to the basics. Imbibition time is 2 days, 0 to 48 hours, and this is the anaerobic phase, which relies on passive diffusion of the plasma to the donor, the graft, and from the recipient bed. And here the graft will look edematous and pale white. The function is to keep the graft moist and capillaries to become patent, and the attachment is by fibrin only. Then comes the inosculation time, which is 48 to 72 hours, and here the kissing capillaries are there between the graft and the bed. There is unidirectional angiogenesis, and the capillary size is about 10 to 11 micrometer. And this is, again, as I told you in a previous lecture, that this is less commonly used, but the concept is still valid. And the peak vascularity occurs around day 7, but the revascularization, the question would be about 3 to 5 days, and that is what you have to remember. So, inosculation, reangiogenesis and neovascularization, this is 3 to 5 days. Lymphatic drainage is established, edema will reduce, the graft will appear pink, and then the mediator is the MMP, matrix metalloproteinase. Cellular hyperplasia begins in about 1 to 2 weeks, and there is epidermal thickness that occurs, which can become even 7 to 8 fold, and the scaling and crusting will be seen, and epidermis returns to the normal thickness by about 4 weeks. The maturation phase is much later, and this leads to secondary this is because of the secondary contraction. The pigmentation, the FTSG has better color match eventually. The STSG may develop hyperpigmentation. We all know this, so sun avoidance is mandatory for 6 months. The reinnervation happens in about 4 to 5 weeks. This is also very important, and completion happens almost in about 2 years' time. And FTSG will have a better innervation eventually than the STSG. And the pain, light touch and temperature. Temperature is the last and pain is the first to come. So, this also I have discussed. Now we come to the last question in this, which is the mangled extremity severity score. So, the question, obviously it is, maybe it's incomplete, because here only the blood pressure and the age was mentioned, and accordingly the options were given. But you should know what is the MES scoring, and it has the components of skeletal or soft tissue injury, limb ischemia, shock, and age in years. So, age in years, our question has 48, so that is score of 1, and persistent hypotension. So, SBP is less than 90, which means the score is 2. So, according to this it is 3, but there would have been even these details given. Maybe we don't have the options, but in the skeletal and soft tissue injury, low energy, medium energy, high energy and very high energy. So, that is how we score. So, 1, 2, 3, 4, and the low energy would be a simple fracture or a pistol gunshot. Medium energy would be multiple fractures with dislocations. High energy would be any high speed injury or a rifle injury. Now, very high energy would be high speed trauma with gross contamination. Okay, so the maximum score is 4 over here. And limb ischemia, pulse reduced or absent, but perfusion is still normal. Pulselessness, diminished capillary refill, not absent, but in the third one it is cool, paralyzed, insensate and numb. So, this is 3. So, the maximum score that one can get is 4, 3, 2 and 2. So, that brings us to 7, 8, 9, 10, 11, right? In MES scoring, if it is less than 7, then usually the limb is salvageable. If it is more than equal to 7, then usually we go for amputation. So, this is also an important chart that you have to remember. So, that was about the INISS recall questions for you.